Good afternoon, everyone. I am Jeannie, one of your co-moderators this afternoon. Before we begin, I have a few reminders to share with you. This program will be recorded, and in the chat, feel free to download the poster, agenda, and the speaker bios. Feel free this afternoon, while you're seeing presentations, slides of interest, use your cell phone to take images. Use the Q&A box to submit questions for the speakers. To receive a certificate of attendance, a link will be emailed to you by 5 p.m. this afternoon. Please complete and submit the program evaluation by Friday, August 29th. Allow 30 days for processing. At the end of this program, there will be 5-question, a poll for you to answer. Please do so. There will also, at the end of the program, will be door prizes, 2 from ARP and ARP California, and 1 from Dr. Pan. You have to stay through the entire program to find out what those lovely door prizes are. So welcome to the Chinese American Coalition for Compassionate Care's Professional Healthcare Forum. Thank you for joining us to celebrate 20 years of community service to the Chinese American community and to the healthcare professionals who serve them. 20 years ago, we were a grassroots coalition serving the San Francisco Bay Area. Today, our community outreach is global. Our mission is to build a community in which Chinese Americans are able to face the end of life with dignity and respect. Please feel free to take a photo of this image, how to reach out to us through email, our warm line on our website. In the chat, you can download the poster, and the agenda and the speaker bios if you've not already done so. After our forum, we have 4 educational series that you might find of interest. On August 17th, there's flower arranging for stress reduction. On the 19th, mindful self-care. And the 20th, AI in healthcare, featuring Dr. Jonathan Chen. If you've not heard him speak about AI in medicine, this is a must not miss opportunity. And then we end with poetic medicine for grief. Please take a photo of this where there's a QR code as well as the hyperlink to register. It is my pleasure to introduce Dr. Emiley Chang. Emiley is an internist and geriatrician with the Los Angeles County Department of Public Health. She is also our board co-chair and our co-moderator this afternoon. Emiley?
Thank you for all of the CACCC 20th anniversary sponsors and grantors. As you can see at the diamond, platinum, gold, silver, and bronze levels, without their support, none of this would have been possible. So I have the great pleasure of introducing Dr. Esther Luo. Her full bio can be found in the webinar chat documents or online. And she is a palliative medicine and supportive care services physician and an associate professor at Kaiser Permanente in Santa Clara, California.
So good afternoon, everyone. I'm super excited to be here. And first of all, I just really want to take this opportunity to congratulate CACCC on celebrating 20 years of serving the Chinese community under the leadership of Sandy Stokes, her amazing team, and the many amazing volunteers. It's truly an honor for me to witness the growth and the impact that this organization has had in the Bay Area, our state, across the United States, and also internationally. And I hope many of you were able to attend last Saturday's event titled Compassion in Action, Empowered Caregiving with Human-Centered AI, with the keynote speaker, Dr. Chen from Stanford, who shared his insights about how to empower caregiving, combining with human and artificial intelligence to deliver better care, as well as Miss Peggy Shin, who herself is a cancer survivor, and her personal journey as a caregiver and a survivor. So today, I will focus my presentation on our Chinese stroke patients and caregivers, so including ways in which we can communicate and support our caregivers, both in the acute hospital setting and across the continuum, really looking through from the palliative care lens. So thank you so much, Dr. Chang, for that warm introduction. And let's go to the next slide. I have no disclosures. Next slide. And here are the objectives. So I hope by the end of today's talk, you'll be able to really describe the role of palliative care across the continuum of stroke, and then being able to apply some communication strategies such as best case, worst case framing, and value-based recommendations when we talk with patients and families facing a serious stroke outcomes. And then lastly, be able to identify cultural considerations when caring for the Chinese patients and families. And we'll talk through how to help them make decisions that are family-centered communication, included end-of-life care discussions. Next slide. So here's the agenda. We'll start with palliative care, and then we'll go into some of the common communication barriers, taking into account our Chinese culture. And then we'll end with some cases, patient stories and cases, and practical ways on how do we go about having these conversations. Next slide. So let's start, next slide, with palliative care. So what is palliative care? So palliative care is a specialized medical care for people who are living with a serious illness. And the focus is really on relieving symptoms. This could be physical, emotional, spiritual. And palliative care's aim is really to improve quality of life and support patients and their families facing through a serious illness through helping them be able to clarify goals of care and then being able to align treatment with their values. So it's not limited to just end-of-life care, and it really should be integrated from early on alongside the stroke rehabilitation and also recovery efforts. So the goal of palliative care then is to relieve suffering, support decision-making, and then being able to promote the dignity at all stages of stroke recovery or decline. So the American Heart Association published this statement about palliative care in stroke in 2024 and really outlined what are the core components of palliative care in stroke care. And these are symptom management, communication and goals, psychosocial and caregiver support, and then lastly, end-of-life care when appropriate. So let's start with some of the symptom management. And I want to share that in palliative care, we often talk about this concept of total pain. And I think this model also really applies well for our stroke patients. So when we talk about pain after stroke, it's easy to focus on purely the physical. But the concept of total pain really reminds us that suffering is multidimensional. So you see here on this picture here that I have that there's an emotional component, there's a psychosocial component, and there's also a spiritual and existential. And this is true for not just the patient, but also the caregivers. Stroke oftentimes will strip away more than function. It affects the person's identity, their independence, and also their relationship with family members and friends. And that impacts both the patient and the caregivers. So if we were only to treat what we can see, so like pain or fatigue, we really miss the deeper source of distress. So then our job in palliative care is really to be able to listen to that unspoken pain and to ask, what else is hurting? And how can we support healing beyond just the body? So patients with stroke have many symptoms after a stroke, and I want to highlight here 4 of the most common symptoms, starting with central post-stroke pain. So this is a neuropathic pain caused by damage to the brain itself, and the pain usually occurs on the side of the body that's affected by the stroke. And it is usually described here as burning, aching, or shooting pain. And it can also include allodynia, which is where even light touch is perceived as painful. And then this can actually develop anywhere between a few days to months after a stroke. Treatment I've listed here can include many of the neuropathic agents, some of the antidepressants, such as the tricyclics, also the SNRIs like duoxetine, or anti-seizure medicines such as gabapentin or pregabalin. The second most common symptom is actually depression. It's actually highly prevalent in the month after stroke. So up to about 25% of patients will have depression, actually even at 2 years post-stroke. And depression not only affects emotional well-being, as you can imagine, it can also worsen their ability to do rehabilitation and affect its outcome. Depression is also associated with patients experiencing severe pain post-stroke as well. So I would recommend that it's important to start medications early, to actually do the screening early and start medications early, and some may even benefit from talk therapy as well. The third most common symptom is hemiplegic shoulder pain. And this is in patients with weakness or paralysis, especially on the one side, and can be due to poor shoulder positioning, subluxation, or spasticity, which can all contribute to this particular type of pain. And the management really includes physical therapy, promoting proper positioning and also mobility, and then alongside pain control and anti-inflammatory medication is a main primary use of pain management. And then lastly, the fourth most common symptom is spasticity. And this is an abnormal increase in the muscle tone causing stiffness, and in some cases, stiffness, pain, and then limits their function. And so treatments here include stretching, exercises, sometimes using muscle relaxants as medications, and Botox injections can also be very helpful. So now that we've talked about symptoms, let's go to the next slide. I'm going to spend some time on this particular slide on the barriers to effective communication, including the providing some cultural considerations, and I'm focusing on a severe stroke. So let's first start with the prognostic uncertainty. Okay, so after a stroke, it's very difficult to predict how cognitive or physical function a patient will regain, or how well the patient and family will respond emotionally, adapt emotionally, living with a future disability. So a meta-analysis among patients who actually went tracheostomy after a severe acute brain injury, and this included stroke, found that by 6 to 12 months post-injury, is that after 6 to 12 months post-injury, about a third of the patients actually became completely independent. And then about a third remained dependent on others for daily activities. And then approximately 10% actually died in the hospital. So this data really underscores how prognostic uncertainty and also emotional burden families carry when they have to make these critical decisions. So in the Chinese culture, this idea of filial piety really makes aggressive treatment the default, because the value is really placed on, as part of that filial piety, on keeping the person alive. And this can actually outweigh the acceptance of a poor quality of life. And I'll go into a little bit more detail later about filial piety. So the next barrier to communication is surrogate decision-making burden. So after a massive stroke, most decisions are made not by the patient, it's usually made by family members. And families they're thrust into making life-altering treatments very early on in the hospitalization. And this may include things like placing a feeding tube or pursuing a tracheostomy, or it's really shifting to comfort-focused care. And in the Chinese culture, it's really less about a single individual that's helping making that decision, and is really done collectively by the family. This can slow down the decisions, but however, it does really ensure consensus and also family buy-in. So I think it's really important for the medical team to really take some time in the beginning to really figure out who are the true decision makers, and then be able to assess how important is it to hear this patient's voice versus it's really been the family who are the ones ultimately making decisions for the patient. Okay, next. So the third communication barrier actually to effective communication is the different perspectives oftentimes we see between families and the medical teams. This again can complicate communication. One of the studies I looked at showed that families oftentimes will perceive that patient experience more pain and suffering than the clinicians do. And then additionally, clinicians may interpret families' hope as unrealistic or as even they're in denial when families are really holding on to hope as a way to cope with the serious situation. I think cultural beliefs can definitely widen this gap. So next. The example is about tube feeds. I think tube feeds in the food in the Chinese culture is more than sustenance, is really a way to show love and is also healing. And so it's really not just a medical intervention. And so oftentimes I think what we see that for many of the Chinese families, this is also tied to the cultural duty and also responsibility. And many Chinese immigrants coming from China or Taiwan may also want to continue feeding tubes even at the end of life, because in their culture, in their country, offering that feeding tube, as I witnessed when I was in China, that is part of comfort. And this is actually very different than here in the United States, where we usually would recommend stop feeding tube when someone is dying. So the fourth barrier to effective communication can result from this potential conflict within or between family members. So different relatives may actually hold different interpretations of the patient's wishes, or even maybe family's wishes, and family members may be at different levels of acceptance about the severity of the situation. And so these conflicts then can slow decision-making and then also add to that emotional strain. And next, in the Chinese culture, I specifically want to call out if the disagreements were between adult children and say maybe the patient's spouse or partner, what I oftentimes see is that the adult children will defer to that of the spouse out of respect, again, in keeping with filial piety. So lastly, another barrier is language. Language barriers is more than just the vocabulary. So next, so interpreters don't always necessarily have a consistent uniform way of translating palliative care. So I've done this where recently I would put in Google palliative care, and what comes up is a definition. I can put in hospice care and the same definition will come up. So because of this, it really can add to the confusion. Next slide. Next. Okay. So I want to then, let's move on to looking at a study. I wanted to share, so this is a recent study that highlights how the barriers in communication can result in significant prognosis discordance between the physicians and also family members. So this is actually a recent cross-sectional study. It was at a neuroscience center looking at how often families and physicians disagree about the prognosis after severe stroke. There was about 222 patients that enrolled, and 193 patients had prognostic predictions available. Next slide. So what did they find? They found that prognosis discordance, which was defined as a 20% or greater difference between physician prediction and the family estimation of that prediction, occurred in 61% of the time. That is a lot. 61, more than half of the time there was a discordance. And what the study found is that the discordance was even more significant when families identified with a minority racial group compared to the white counterparts families, again reminding us that cultural experiences and also health equity issues deeply impact communication. Another interesting finding of this study is that when nurses perceived that families had a poor understanding, those families were much more likely to have discordance about prognosis. So how then do we communicate, especially in the face of so much uncertainty then? So let's then go, next slide. We're gonna then focus the rest of this talk on some very practical skills. We're gonna start with this particular case, focus on an acute a stroke. So this is a real patient that I've seen, 74-year-old Chinese-speaking woman. She had a history of irregular heart rate, some kidney disease, and a high blood pressure. She actually initially came into the hospital to undergo an elective back surgery, and then post-operatively, she was found on CT to have a very large MCA and ACA infarct, and there was malignant edema, a petechial hemorrhage. Her initial NIHSS score was 20, and then she underwent thrombectomy, which showed very good flow. Clinically, on exam, she had aphasia, left hemiplegia, and family was facing decisions about possibly doing this really aggressive surgery to decompress the brain if the patient failed medical management, and they had to make decisions about a feeding tube. As you can imagine, this is very, very stressful. So how do we then communicate the seriousness of the situation to family members? And I think what I typically see the medical team do is actually the more serious the medical situation, the more medical terminology is used to convey the seriousness of the situation. And what I propose here is that instead of doing that, we really need to, as a medical team, communicate clearly using layman language rather than medical jargon. And I want to just go through some of these examples. So instead of saying medically, your mother had a large right MCA, ACA infarct, and malignant peripheral edema, what's actually more helpful to say is, and this is on the right side, that your mother had a massive stroke that damaged large parts of the right side of the brain. And the brain is very swollen, which may make things worse in the next few days. And instead of saying there's a high risk of herniation and increased intracranial pressure in the next few days, instead what we can say is that over the next several days, the swelling can get worse and cause more damage. And if it gets bad enough, it can shut down the brain's ability to function. And then instead of saying if she fails medical management, and we say this a lot, I hear this a lot, is if she fails medical management, she would progress to brainstem compression and then neurological injury and death. But instead, what would be helpful would say something like that if her body didn't respond to treatment, the swelling could affect the part of the brain that controls basic life function, and she may not survive. And I think as we deliver this serious, oftentimes shocking medical information, we can really also acknowledge the emotions that our families are dealing with as they hear this. And so we can say things like, I wish we can predict more clearly how she would do, and this is an incredibly difficult time, and we'll be here to support you through it. And when we combine a clear, compassionate explanation of the medical situation with acknowledging the emotions, I think this really helps families feel seen and feel supported and better understand prognosis while feeling emotionally supported. And how do we then communicate our support? I want to share two specific ways. Communication techniques. And one is and this helps to build the trust quickly. And so one is just to simply acknowledge, okay, acknowledge the burden and acknowledge the uncertainty that they're carrying. So you may say something like, I can see how hard it is to be asked to make these decisions. And I wish we can predict more with more certainty. Another way to support would be to reassure that there will be continuous support. And so this shows really the non-abandonment. So for example, you can say something like, really, no matter what happens, we will continue to care for your loved ones. So how do we then help family members who are thrust in the midst of this acute, serious situation to really plan for the what ifs? And I want to share this best case, worst case framing that as the medical team we can use. This really allows families to hold on to hope while gently prepare them for more serious outcomes. So, and it's also a non-threatening way, I think, to also start introducing advanced care planning, a co-status discussion, and perhaps even future care transitions without having to force a decision in the moment. It also acknowledges the emotion, respects the uncertainty, and then really invites kind of this shared planning. Okay, so you can say, you know, say for example, in the best case scenario, that in this best case, she'll have significant weakness on her left side and may need long-term rehabilitation course. And even then, she may still need help with daily activities at home. And then the worst case, she may deteriorate and require further procedures like this surgery to the brain, and she may not survive. We're still early in the course, and we can't predict exactly how she will do. Her outcome will likely fall somewhere in between these scenarios. So the clinical pearl with using this is really, we hope for the best and really plan for the what ifs. Now, how do we communicate when oftentimes emotions are very charged, right? Very charged. Next slide. So now I want to provide another practical tool called the nurse mnemonic, again, as a framework to respond to emotion. And this is oftentimes very helpful to use when the communications are, they're high stakes situations, just like a devastating stroke or end of life care discussion. So N starts for is for naming. So we want to be able to name the emotion and how they're feeling. So you can say something, wow, sounds like this is very, very overwhelming. And use for understand. So showing your understanding, verbalizing actually your understanding that I can only imagine how hard this is for you. R is for respect. So again, verbally voicing, acknowledging the respect to family members that, you know, that they've been very thoughtful in advocating or caring for the patient. S is for support. As I mentioned in an earlier slide, making sure that they know no matter what happens, we're there to support them. And then lastly, E is to explore. Sometimes it's to ask more questions and being curious, right? What has been the hardest part for you? So hopefully many of you guys can be able to try using this nurse mnemonic when really faced with a lot of emotions with patients or family members. Okay, next slide. Okay, I want to spend 2 slides really talking about our Chinese culture and call out on some specific things. So as many of you already know, that family-centered decision-making is important in the Chinese culture. And so it'll be very important to identify who in the family are the ones making decisions. I want to say that don't assume that the English-speaking family member is necessarily the one that will make decisions. I think oftentimes usually it's an adult children who's much younger, who's like the main person contacting, you know, interacting with the medical team. And I think the medical team sometimes just assume that that's the decision maker, and we rely on that family member to then pass on the information when truly the authority actually rests potentially on a non-English speaking elder. So in that way, in that sense, when you're delivering key medical information, it's important to make sure all the key stakeholders are there. You're using a medical interpreter when providing updates or making decisions. This idea of filial piety sometimes can drive family members to do everything. So filial piety, 孝, really is pursue this aggressive treatment out of duty and out of love for their loved ones, even when the outcome may be uncertain or the interventions may come across as burdensome. And why? Well, because sometimes choosing comfort-focused care may feel like the family members are giving up, or they're actually being very disrespectful. So family members want to save face and they want to do everything. Okay, so we want to be able to reframe comfort care as a way to honor and to protect the loved ones from further suffering. Something else that is common and I think is very effective in terms of communication in our Chinese patients and families is this indirect communication. And I think what I shared earlier about the best case, worst case framing, it's a great tool to provide this indirect communication. Let's go on to the second case. So this second case highlights during the chronic phase, and this is the same patient. So this exact patient we just talked about, she survived that acute period of her stroke. She had persistent aphasia, left-sided weakness. She's not able to walk, and she remains dependent on families for all of her activities of daily living. After her acute stroke, she went to the nursing facility for rehabilitation, was there for a long time, and was rehospitalized because she had COVID infection. She also had recurrent urinary infections. She did have a feeding tube placed to help her swallow because she had difficulty swallowing, and family was really uncertain about, gosh, how aggressive do we want to do life support if she got sick again? And so, but she ultimately did go home, and we saw her back in the clinic for palliative care follow-up. So next slide. So then in this chronic phase of a patient who survived a serious illness in which their function has clearly been affected, okay, and now they're dependent on the family for care, how do we then talk to our patients and families? So I think in this phase, we find that patients have profound disability, fully dependent, and we see that families continue to provide extensive care, oftentimes out of filial duties. And this moral, emotional responsibility actually doesn't decrease over time. In fact, it can actually become more heavy, and particularly for adult children who then assume kind of the day-to-day caregiving, oftentimes with very little recognition or support. I think also want to call out that sometimes there's a cultural expectation to kind of endure it silently, to care without expressing that hardship, because that's kind of the expected thing to do, that is, you care for your loved ones. So seeking help, hiring caregivers, outside caregivers, or placing a loved one in a facility really can feel like the family members failed, or it may feel like it's dishonor. So the communication in this phase oftentimes is to support the caregivers who may or actually may not be the actual decision maker, okay? So if the family member caretaker is not the decision maker, then obviously the discussion about treatment goals, co-status will need to be had with the decision maker in addition to the family caregiver. And so I provided here this, an example, what you can say to the caregiver. You've been asked to make decisions for your loved ones for a long time now. It's a heavy role. So again, acknowledging how challenging that's been. Let's talk about whether this test or treatment can actually help her live better, or is it just going to prolong suffering? You've carried a lot for a long time. It's okay to feel tired, conflicted, overwhelming, kind of giving permission for the caregiver to voice how hard it has been. I also want to say that it's really important to have, if you have the service available, to have outpatient palliative care team, specifically the social worker who can then support the caregiver. They can validate the caregiver distress in a culturally sensitive way. They can also provide some very concrete support, right? Family leave options, respite care, home aides, support groups, for example, and they can really bridge conversations about guilt, about pride, and also letting go, and more effectively than what the physicians can. Also during this stage, we spend a lot of time also communicating and supporting the caregivers and family members about complex decisions. So for example, in this particular patient, this question came up about colonoscopy screening. Is that still needed? Do we still do it, or do we not do it? So we really took the time to talk through that, weighing the pros and cons. Is that in line with the patient and family values? We also, for this patient very recently in the clinic, revisited what matters most, what was most important for her. And for her and the family, it was to be with the family, despite being in a very debilitated state. And she was very clear that at this time, she wanted to try everything possible to keep her alive. So that would mean full attempting of CPR, and families understood that as well. And then lastly, in the outpatient palliative care, we helped with some coordination of her care, working with her primary care physicians, such as referring to home health physical therapy. We also referred her to a community-based neuro rehab acupuncturist, which the family really appreciated. Okay, next slide. We're going to go to the third case, and this case really highlights the end-of-life phase of a patient. So this is a different patient. This is a 91-year-old Chinese woman. She has some congestive heart failure and also high blood pressure, hypertension. She was found down one day, was found in cardiac arrest, was resuscitated in the field. 911 was called. She was intubated, meaning the breathing tube went down. And on imaging, she had a massive right-sided stroke. She was admitted to the neuro intensive care unit, and she had very poor neurological prognosis. So in this case, the palliative care team in the hospital was consulted really to help talk about decisions about tracheostomy, about putting in a feeding tube, and really what is the goals of care because the prognosis was so poor. Now, this patient's daughter expressed, gosh, I know that my mom would not want to live where she was totally dependent on others and may not even know who she is. The husband was in distraught, and he had many, many questions, and he was really not sure about, is this the time to really let her go and switch to comfort? So in this situation, next slide, I want to offer a roadmap to communicate in terms of end-of-life care discussion, especially in the intensive care unit. So let's start with, so when we start conversations like this, and I see that a lot of medical residents early on their training, they go straight to talking about the procedure that needs to be done, okay? And I would say, don't do that. I think what's most important is actually start with the patient and family. Start with their values rather than their procedures, okay? So really asking, before we start talking about what's possible medically, can we really revisit what matters most to her and also to the family members? We want to then really acknowledge emotionally how challenging this is and how maybe emotionally the daughter and the husband may be at different places, okay, both emotionally and also informationally. And I think that's normal, okay? So naming it out loud really helps reduce that tension. And the other thing I want to emphasize here is that usually when families feel heard, they actually become more able to hear and process the medical information that we're offering. Okay, so, and that's key because it's not just delivering facts, but we're really creating a space in which the facts can be actually processed by the family so that they can help, they can make decisions. Okay, so the next part of this roadmap is to be able to move to clarifying the likely outcome of the intervention using very plain, compassionate language and not medical jargon. So for example, saying something that if we were to do a tracheostomy and a feeding tube, she may survive, but it's very unlikely she'll be able to talk, walk, or care for herself again. And I think, again, this reframes the conversation around the person, around family values, not on the crisis. And so after we're able to do that, then we can try to reflect back the family's voice, right? Reflect that back side. As a family, sounds like you believe that she would want to totally live dependently like this. This will help us guide what the patient would want and what the family may choose. So then we want to be able to then offer a value-aligned recommendation to really help them feel that there's a path forward that really respects what the collective patient and family would have chosen. And so we can say something that is reasonable then based on what we've heard to focus now on comfort and avoid treatments that would prolong a life that she and the family would not have wanted. So I do also want to call out, in our Chinese culture, talking about death remains a taboo subject, okay? Next, so it's important to sometimes provide language about prognosis in a very indirect way. So for example, and part of it is talking about deaths so directly may come across as being disrespectful or frightening or even unlucky. So families oftentimes want to avoid saying the word death, especially in front of the patients. And I think, okay, so we can use what I provided earlier, this idea of best case, worst case. It's a great way of doing this. And then also, here's another example of indirect communications about prognosis, saying something like, well, it's actually best for families to really see her now and not wait for another week. Okay, so another indirect communication method. Okay, all right, next. So here I want to summarize really the key pearls across the stroke continuum. So we started off today with an acute stroke. And I think in that setting, it's very important to pair the clear medical information with layman language and acknowledge acknowledge how emotional this can be for the patient and family. And then being able to recognize filial piety as a key Chinese cultural consideration when we care for our Chinese patients. Being able to identify who are the key family decision makers, recognizing it's not always the person that can speak the best English, for example, and then also be able to use best case, worst case framing to support prognostic uncertainty. And then as we move to the chronic stroke stage, be able to use this time to reassess goals as the clinical picture evolves, continue to provide emotional, psychosocial support for the caregivers, and then offer guidance in medical decision-making, which is really ongoing. And then at the end of life, really be able to facilitate using that roadmap, a structured, compassionate communication, really that's anchored in the patient and family values, using indirect prognostic language and normalizing comfort care, and then offer the value-aligned recommendations. Next slide. Here are some caregiver resources for people to share with their patients and families. Next slide. So then in summary, next, palliative care improves quality of life by addressing symptom burden, emotional distress, and decision-making across the continuum of stroke. Next. And it's important to integrate palliative care early, not just at the end of life phase, but also during the acute and rehabilitative care as well. So communication tools like best case, worst case scenarios, and also the nurse mnemonic really can, and value-based recommendation enhances communication in high-stake moments. And then recognize and acknowledge cultural considerations when we care for Chinese family members as a unit. And then lastly, sustain collaboration between neurology, palliative care, and other care teams to really improve the alignment of treatment for patient goals, help avoid interventions that are not aligned with the patient family values, and continue to support our caregiver well-being. These are my references, and thank you so much.
Thank you so much for giving such a comprehensive talk in a condensed amount of time. I really appreciated the way that you shared practical tips and suggested wording on how to improve communication and understanding in different communities, particularly with a focus on Chinese Americans. And I also wanted to reiterate that all of these skills are not just the domain of palliative care, and that all healthcare providers can utilize them to improve care for our patients. So thank you very much for sharing your wisdom with us today. I wanted to let the attendees know that we will be monitoring the Q&A box, and we will have a question and answer time at the end once all of the speakers have presented. And so I see there's one question already, and so just letting you know that we'll address it in the Q&A section, but please keep putting your questions in the chat box or in the Q&A box. Either one is fine. Okay, so we have our second speaker, Mindy Wen, who's a nurse practitioner, palliative care nurse practitioner, and social worker. So she works at Alameda Hospital of Alameda Health System, for specifically Highland Hospital. And so she'll be sharing about her experiences today.
Thank you so much. Everybody hear me okay? Thank you so much for the introduction, and thank you, Dr. Loeb. This very comprehensive message all the way from acute to end of life kind of sums it up what we do, what I do daily as a palliative care team member. So I have the luxury right now to talk a little bit about my involvement with CACCC and how it kind of helped me grow personally and professionally. That's the first part of my talk. And the second part, I really want to kind of go in a little bit, give more example about a few points that Dr. Lowe mentioned. So that's we conclude my talk. So I joined CACCC when it first started in 2005. At that time, I was a hospice volunteer for already 2-3 years. And I kind of hit the wall a little bit, especially with the Chinese patients that I've been seeing. So for example, my first ever hospice patient is this lady that has ovarian cancer. She had like kind of distended stomach and has fluids all accumulated out her feet and her hands. And this really, really sad kind of like undertone kind of covering the whole process that I was with her. And there's a lot of unsaid things that she wanted to say but couldn't. Maybe didn't have the skills, or maybe that's not the right practice in the culture. And I also see the family member, two very young son, young meaning in their 20s, and her husband's really struggling. So everybody's like kind of in this silence, and I have no tools to how to bring it up. So I remember spending hours kind of rubbing her feet, her hands in silence. And I know that's part of like companionship and really the part of hospice care. But I hope that I have the tool to be able to talk to them and really break that kind of culture of like being silenced, and really curious also about, did the patient know that she's dying? Did she have a chance to say goodbye? Did she have able to tell the families that, or the family tell her that like how they're feeling about her departure? So all of that, as you can imagine, when I find that there's organizations that will talk about end of life, I was so thrilled. I learned so much, and thank you, Sandy, for being such a great leader from day one. Her energy is also high, and her leadership is so strong, and her compassion is unmeasurable. So fast forward, I kind of faded out a little bit after I become a psychiatric social worker, starting my new career. But the skill that I learned with CACCC have like cover all my entire career, all the grief, the loss, how to deal with that, how to sit through all the difficult moments. And when I was serving patients with severe mental health issues, and it's all about, can you imagine that their life was still stolen from them, their hopes and dreams were challenging to access when dealing with the illness. So all the skills that I learned has so helpful. And I kind of will engage with CACCC and my learnings when I became a home-based palliative care social worker. Over there, I visit patients that in the last year or half of their life and really could not leave home. And so I partner with a nurse practitioner providing medical care, and I providing psychosocial supports, kind of do some intervention as well, therapy, anything is needed. I love my job, and I kind of sometimes will have joint sessions with the nurse practitioner, and then I kind of observed what Dr. Lowe was talking about, like all this time that palliative care team was able to talk to families about their goals, their priorities, what are important when the next time comes. Would you thinking about kind of give it a full force to see whether things can change in the hospital, or it is time to think about kind of being at home with enroll with hospice, or what will be your goals? So those conversations were so fascinated. I'm thinking, wow, if I can do that, that would be great. I'll be so happy for the rest of my 20-some year more career service. So that is kind of the last reason for me to return to school and get my medical side of into education. I'm so happy with that. When I graduated, it's the pandemic. So nothing helps me more to see patient and family at their home settings, being a hospice nurse, and then now become a nurse practitioner in Alameda healthcare system. So that's my first part, and happy birthday to CACCC. I want to grow old with you and learn a lot more from you and from everybody that in the field, and just all this great compassions. So that's my first part of my talk. Wow. And I wanted to kind of like touch points on a couple of the points that Dr. Lowe already said and said it so well. I wanted to share one thing that really helped me is the phrase that "tell me more." Whenever I think about that phrase, I'm thinking, wow, I really need to be more curious about the differences. For example, like I came from Canton, and when I became first became a hospice volunteer, I heard this phrase said like, oh, my loved one cannot die at home. And I was like, wait a minute. Why is that? Because my grandmother died at home in Canton, and her body was like moved from where she was staying and out in the living room. And everybody came, and it was like kind of like a very comforting experience. So I was like, I don't expect that. I don't have the same experience. But then again, that means that I stuck in my bias and my experience and thinking that could be the only explanations for things. So tell me more, like it's a phrase that we use a lot in palliative care, really show our curiosity, and also a reminder for myself. So I know you use it a lot. If you haven't tried it, it's like makes wonder. One time I walk into the patient's room, and there's a sister grieving the impending death of her brother. And I said, wow, you're such a great sister. I'm using the nurse phrase, and such a great sister and supporting your brother. And she turned around and said, I just want to wring his neck. I was like, okay, wow, tell me more. That saved me. And all the way to another phrase that like kind of when people were saying that I really need to, I can't take my loved one home. And that's the time that I say, wow, please tell me more. Sometimes people will say, tell me that, it's unlucky. Those things that we could not change. We could not change the family's members, like 20, 60 years of preconceptions. But sometimes people will say, I really don't know what to do. I really don't know what to do when they're taking their last breath, or before that they're having symptoms. That give me a cue about like, if we can place that person's in a skilled nursing facility, or if I can talk to hospice and call them and say, hey, this is the family that really needs some support. I think they have all they need to care for the patients. But if you can get your nurse there every other day, and your social worker one time a week, and then your chaplain another time, maybe you really can lift the patient's family up, and they can really take care of the patient. And that's their dying wish, to be at home. So tell me more have shared and gave me so much freedom and ideas about how to best take care of a patient. Like Dr. Lowe said, like we are the culture that kind of use indirect communication. So that kind of draw that out, and then again, really helped me with my preconceptions. I think Dr. Rowe talked a lot about like reframing, which I was going to talk. So I'm going to kind of jump through that and think about, talk a little bit about, let me see, I have 4 more minutes, a little bit more about family buy-in. Being a social worker, being my background, I have so much curiosity and into the family dynamic. Like Dr. Lowe was saying, like, it's not the English person that in the family that might not be the main person, but we call them. The family want to make it easier for us to have an English speaking family member to get all this information. But sometimes they're like the grandchildren, and who's making decision is their father or mother is the patient's children or their spouse. So I really want to kind of like look into what the family dynamics are. I have patients that has like 8, 9 children, and whenever they're at bedside, I just talk with them. To me, I feel like whoever they're, like Dr. Lowe was talking about, everybody's make decision as a group. And if we have to share the votes divided by 8 pieces or how many children they have, I really want the buy-ins from them. So if I see them in person, I don't have to reach out to them because I call the spokesperson. But if I reach out to them at bedside, I really want to explain to them, okay, your loved ones really have a stroke. It really affects their central system, their way of swallowing. I know food is really, really important, but see, the patient's also struggling with aspirations, and they cough and they really look like they have a hard time breathing. So that's really helped me really educate the family. So to kind of like be friends with them and give them education. Sometimes like with patients with stroke and dementia afterwards, it's a long road. Sometimes they get a little bit better. Everybody's like rallying and have hopes, and sometimes we'll build relationship over a couple hospitalizations. And then the fourth one, when the patient comes back, is all the symptoms like presented end of life. And the patient said, yeah, I remember you saying that the first time, that eventually that will come. So again, the encourage or the invitation and saying that, you know, sometimes we need to zoom out a little bit what we're doing daily and really explain to the family member that, like, you know, okay, this episode will get better. And sometimes, as we talked about, things were coming, will keep happening, but we're going to be here with you every step of the way. And I said, I hope your loved one don't come back, but if they come back, we're right here with you. And I will be, I will be kind of relating to the information to you the same way. So my last point is, I have like 2 more minutes. My last example would be like kind of eating, like kind of reframing. One of this really lovely 80-some-year-old gentleman came in, had stroke and has dementia and slowly unable to swallow and had infection. So he came to the hospital, and he was cared for by 2 lovely daughter. And we're talking about eating. We're talking about the future. If we're able to get over these infections, the recurring kind of aspirations and infections gonna happen. And I remember the older daughter was asking like, oh, what happened? I heard, what happened if you couldn't eat? I heard when I was growing up in China that rather die as a full ghost than die hungry. I don't know what got into me. I was like, wow, this time for reframing. I said, wow, yeah, true. It's really true. Also, over there, their age that they're growing up, they really don't have food to eat. That's probably kind of affecting their way of seeing. That's the saying. But right now we're so rich, we have all this food. But again, like kind of that's many conversations after. I just want to share that. Fast forward 2 years later, I call up the family and say, how's your father doing? They said, great, my father's doing great. He is just like eating. We're seeing him every day. And I said, wow, you know, that's wonderful. I'm so glad that he's doing okay. And because of all of your care. I said, wow, now you have a little bit time to kind of rest. Would you like more information? And the daughter said, absolutely. I said, okay, let me get your phone number. I'm gonna send you a website that you can get all sorts of information. And she said, okay. And guess what I sent to them? The CACCC website. I said, go and check that out. There's so many talks and so many things that you can learn. And so that concludes my talk, and I see you in the panel discussion.
Thank you so much for being a proponent and advocate for CACCC and making sure that the information gets out to the community. I also appreciated how you provided some personal experiences to highlight some of the points that were made in Dr. Lowe's talk, including the phrase tell me more, that posture of curiosity, that really helps bridge cultures and languages, and really helps you understand other people better. Um, and then also being aware of family dynamics, and the whole concept around food as a sign of love. So next we have our speaker, Tenny Tsai. She is a family caregiver and patient and family advocate who founded the Asian Community Fund to support Chinese families living with Alzheimer's. And she facilitates the Alzheimer's Association Chinese Learning Circle since 2013, and has been a board member of Alzheimer's Impact Movement to help shape national Alzheimer's and dementia policy, which is very much needed, giving a voice to those who may not have the voice to advocate for themselves anymore. So we're here to learn from your experiences. Ms. Tsai?
Okay. Hi, everyone. Good afternoon. I'm really appreciate this opportunity. I'm speaking, I'm not professional of any kinds, but I'm using my own life experience since that to share with you my caregiver experience and some points I would like to share with you. I gonna focus on the Alzheimer's dementia type of caregiving. It's not only that's the area I spend the most of my time with, but I know for the elderly people or even after stroke, people have a dementia symptom. It's a very high percentage, and so I think one way or the other, you probably can relate it to what I'm about to share with you. Um, my first caregiving is for my grandmother who that was about 40 years ago. At that time, I don't know what is the Alzheimer's is all about. We about a couple of 3 years take care of her without knowing what she had, and just a terrible memory problem. And then we finally understood, but there's still very limited information around. And we took care of her for 10 years until she passed away. And at that time, I realized that information is so little, and I wanted to be able to provide people the support group is so important because I thought my family was the only people suffer from this type of disease. I didn't know there's actually many people were suffering, but so when I went to the first support group, it really helped me open up. Then it's my mother have an MCI, mild cognitive impairment, about started, I would say, 18 years ago. But for the last 12 years or so, she was fine until she also got complicated with the cancer diagnosis. And so it's really difficult. But I want to ask you one question first. When I was serving on the Alzheimer's Association's on the national board, this one question was asked us that if you have a choice, what will you be? You want to be a patient or you want to be a caregiver? I want you to all think about this for a minute. I shot out my hands right away. I say, I want to be caregiver. I mean, I want to be a patient. I don't want to be a caregiver. I mean, without even thinking, it's so hard to be a caregiver in general, but especially hard for if you are the if the patient has Alzheimer's or dementia. Today, how to be a good caregiver, I think there's all kinds of materials or information that you can look up. But I just want to point out a few points that it's kind of sensitive. Maybe not too many people talk about it. And so the first one, I think right away, no matter what kind of caregiving you are doing, I think the first one, you want to find the proper diagnosis and find out the stage of the illness, especially like Alzheimer's has beginning, early stage, middle stage, and the late stage. And you want to know what to do, and then you want to find out the medication. And I'll talk about the medication. It's really interesting. I don't know how many people, the caregiver, they will know how to pronounce the medicine. And usually they will tell you this is the round one, white collar, or pink one, oval shape. And this is just so dangerous that I have seen people and they just take out the prescription bottle, they put it in the pill box, and you don't know what they are eating. But I, I I think one of the difficulties the caregiver is facing is a caregiver burnout, or you can call it compassion fatigue. I want to share with you, not too easy story to share, but just recently, my father passed away in January, and my mother and him they were married for 72 years, and 8 years prior to that they knew each other, so it's 80 years life partner together. And just imagine when he passed away, my mom, I mean, we were with my father until the end, every step away. It was a beautiful experience. And he was 100 years old, by the way. But when my mom, after we come home, the next day he said he want to go see my father. And then so we had to tell her that, Dad is already in the heaven with the Lord. He's gone. And my mom would not believe it. And we tried to tell her again. So it's like rediscover her husband died. And we keep on going through this. And she was just she's 93 years old. It's very Chinese era that she felt that she had to express her grief very loud and very devastating, crying and, stomping in her feet, and then hitting her chest. And then she said she want to die. My father should not let her alone. And I tried to reason with her, and I should know better. I facilitate support group. I told people not to reason, but myself, I just keep on trying to reason with her. And then I was so tired of explaining to her. I finally said, "Okay, go ahead." And I know later on I regret I was so cruel. I said, go ahead. I said, you want to die? Go ahead. But I cannot stand it if I lose you. So if you think this is the right thing to do, I'll follow you. I'll kill myself too. And so it just so ridiculous become. And she kind of got really surprised. What am I talking about? So she stopped. But this kind of caregiver burnout, it's really difficult. The story incident happened is that another day like this, my mother was thinking about my father and looking for my grandmother, which passed away 30 years ago, and she has no memory. So now has her loved one, or I have to tell her again that they passed away. So she cried and cried, and then she finally get to a point she could not catch her breath, and she said, my chest hurt. Then we said, well, I said, if you cannot come down, I have to call 911 because I cannot take a chance. So I called 911. The ambulance came, the paramedic and the fire truck. So can you imagine 7 handsome big guys just walking to her bedroom, and she turned around and looked at this. She stopped. She didn't know what happened. She said, what's going on? I said, you say you cannot breathe, so I'm going to take you to the hospital. And then she was so upset at me and said, no. And, my daughter kept on telling me, you got to redirect them. But I couldn't. I still keep on reasoning with her. So at that moment, I have caregiver call my brother to come to rescue me. And then on the way here, my daughter told her, "What I don't care." Told him, "I don't care what story you're gonna tell him, but just redirect him." So when he comes, he sit down with my mom, and I have to deal with the ambulance. So I kind of go out of the room, but after I come back, I just watch my mom come down, and you cannot imagine, you cannot believe what kind of story my brother told her. He said, how was work? And he said, you know what? Something really crazy happened today. There's a whole bunch of monkey come to our hotel. And I don't know if you remember a few months ago, there was news about monkeys got out the medical lab, and they only have half of them recover. Maybe that was my brother's inspiration, but she said that all the monkeys, so my mom just listened very attentively. She said, "What happened to the monkey?" She said, "But you cannot believe, not only we cannot catch those monkey, but crocodile come out of the swimming pool." And so they ate all the monkey. And my mom just, I mean, it's so ridiculous, but it worked. Okay. And here I was hiding behind the door. I was so afraid of my mom gonna see me, gonna ask me about my grandmother and start crying again. So I was crying and laughing all in the same time. And I realized there's no way I can do this all by myself. You know, the care is a layers of the caregiving. It takes a whole bunch of people. You need to let people know you need help. And so you can take a break. So you can be a daughter. You can be the son. No, I don't want to always be a caregiver. In my family, I'm I'm the caregiver. I'm the main person coordinate with everything. And I have one sister. She doesn't believe in that. She believe enjoy life. So she take my parents out for meal to dinner, having good time. And here I'm here, try to make appointment, arrange all the doctor's appointment, all the brains, you know, MRI or whatever, all the different things, difficult things. And I realize there's a balance we need to strike. And, you know, and my mom facing the difficult decision is that now she doesn't cry that loud anymore. But then she still is facing the decision. We have to tell them. She said, "You know what? Your dad was not like this. Before, if she come home, he want to come home late, he always call me ahead of time. But now he doesn't. And I know he went out with another woman. And so, and he would, can you imagine that you were with somebody for 80 years and that person is actually run after another woman? So I want to ask you, what will you tell your mom that her husband's dead, or that he betrayed her and went out with another woman? We decided to tell them my father's passed away. And then she cried. She said, "No, I don't want to believe it." So I talked to a friend who's a therapist. She told me the grief, this kind of grief probably never gonna be gone. It's like a pendulum. And in the beginning, it just swings very, very strongly. Then eventually just gonna be slowed down, but will not stop until the day she died. And I think it helped me. Even the answer is not what I like to hear. I want my mom to just totally be fine. But I think if I can accept that as a reality, then my expectation will help me to deal with it. And so, and I also, I said I have a difficulty to just relax. The caregiver, we need to relax. We need to rest. But I can't. I just tell you, it's kind of ironic. The other day, my son was driving my new car, and I put my home address as home. And then he all of a sudden he looked at it, he's laughing, and because we're gonna go to my mom's house. And she said that the computer recognized Nanai's house as work. Like that's the work I'm going, because I go there every day. So they automatically plot it as a work. And that's just to tell you the intensity that I've been caring for them. And I realized that I told the therapist, I said, "What do I do? This is not, I can't help it. I need to go to, I need to help. If I don't go, I feel bad." And so she said, "How about this? That if you allocate, say 2-3 hours, once a week, you want to go do something, and you call, because every time when I hear the phone call, I feel this emergency. I can't stop it. I can't help it." But then she said, "Then tell your caregiver, your parents, and your siblings that you're gonna go do something for yourself, and don't call you unless it's a life and death." So you kind of set a boundary. So that is something I guess still need to try. And I think, there's also, do not judge people when they make a decision. For example, whether they not keeping them at home, send them out to a facility because you cannot handle it. But I also experienced situation, the spouse, they're actually a wonderful husband and wife to each other when they were healthy. But after this long dragging caring, there's no life for one of the spouse that who's not suffering from dementia. So they decided to make some arrangement, or some even start socialize with another friends, but then still continue to care for the person because financially they could able to provide them. But I saw the situation, and then the wives, because they used to whole group of people socialize together. So all the people, they despite the husband doing that, even he still care for them, but he absolutely has no life, and he start dating another person. And I'm not judging right or wrong here, but I just want to share with you, I finally realized that if you are not in somebody's shoes, don't judge them, but support them. If you love that old friend, just support them. They have their own, they still have a difficulty to feel the loss of their spouse. I realize my time is up. I know there are so many I want to share, but I think to have a caregiver, although it's very difficult, my mom used to tell me the best gift we can give it to you is that if your dad and I stay healthy, you don't have to take care of us. But there's a time when they live long enough, sooner or later you have to take care of them. But I think this is an opportunity for us to express our love and the depth of love that we can give it to them. And it is privilege that we can be a good caregiver for our loved one. Thank you.
Yeah, thank you, Tenny, Ms. Tsai, so much for providing the caregiver perspective and sharing with such honesty and vulnerability. It's not easy being a caregiver. It's easy to just assume from a healthcare provider standpoint that this person will take care of everything. And all I have to do is talk to that person and then things will happen. But on the other hand, that caregiver also needs support. Yes, they're supporting the patient, but they need support themselves. There's a lot of mixed emotions, for example, as with the role changes, and also needing to negotiate with other people in the family as well to make sure that you're not the only person that is doing the bulk of the caregiving. So yeah, so these are all challenges that there may or may not have a right answer, but it really depends on everybody's individual situation about what the correct answer is. But yeah, thank you again. Okay, so for our final speaker, we have Master Longyun, who's a board certified chaplain with palliative care and hospice advanced certification. She's a certified grief counselor and is ordained as a Buddhist nun in the Zen Buddhist tradition. She also holds a PhD in religious studies. So welcome, Master Longyun. We look forward to hearing what you have to share with us today.
Thank you, Emily. Thank you. Good afternoon. My name is Yun. You just call me Yun. I'm so glad to be here to share my clinical experience as a chaplain at hospitals. So today I'm going to share how does a chaplain to collaborate with the medical team to provide effective services to patients and their loved ones. So what does a chaplain do? Yeah. So what the hospital think I do? See, usually hospital staff, they think, as a chaplain, I provide blessing to the patient at the end of life. So they call me to offer blessings or chantings. This is what many of staff of hospital, they think, what I'm doing as a chaplain. What my friends think I do. So when they know as a monastic, I'm a monastic, come to the hospital, they think, okay, Masters, you are wonderful. I know you go to hospital to experience your love and compassion and to save the whole sentient beings in the hospital. That's what my friends think, what I do. And what I think I do before I receive these trainings. So I think, okay, so now I go to the hospitals. I will lead the go to chant, lead the family members, even staff patient, lead them to meditate, lead them chantings, and make sure everybody they can be free from the life circles we call samasara in the Buddhist terms. That's what I think what I'm going to do as a clinical chaplain at the hospital. And what some patients think I do when they heard the term of chaplains. You saw these pictures, right? It's in the Asian tradition, we call them black and white impermanence as two deities. So they are in charge of escorting the spirits of the dead to the underworld. So when the patient heard about chaplain, yeah, someone mentioned, no, I don't need chaplain. I'm doing good. So why? Why need chaplain? I'm dying. So that's many times I encounter in my clinical services. Either I present a bedside when I'm rounding, or staff make a referral and ask the patient family, do you need a chaplain? That's the answers for many of the patients. And what society think I do as a chaplain, they think, oh, you must go to the temples, go to temple because that's your temples. Hospital is temples, right? As a monastic, you go to teach them. And you go to fix them, you go to change them. Tell them what's right, what's wrong. Tell them why you got disease, because your wrongdoings. The society, they think that is what a chaplain do. And what I actually do in the hospital services. As a chaplain, I present a bedside. I provide my compassion listenings. I respond to patient and family emotions. And I help them to find their coping skills. So these slides, yeah, we can discuss, what does a chaplain really do at the hospital? First one, assess needs. So I provide spiritual assessment, by using professional models to address the patient's spiritual need. We have many spiritual assessment models. The one I'm using also is one very popular. We call M model. We call assessment intervention models. In this model, we discuss when the patient, they are facing life-threatening illness, when they are in crisis. Usually they have three types of spiritual need. First one is they need meaning and direction. Second one, they are self-worth and belonging to community. The third type of spiritual need is reconciliation and to love and be loved. So I do my spiritual assessment, then address a patient need, what they really need at this moment. We find the primary need at that moment. The second, exploring, what I'm doing for this. So usually for this one, I will assist patient in exploring their inner strengths and peace. So because of when the patient diagnosis as a serious illness, usually the connection is broken. The connection with themselves, with their family members, with their friends, with societies, and with their divine, that connection is not normal and not like before. So I need to assist them to rebuild that relationship, the relationship with themselves, with their family members, with their friends, and with societies, and with their divines. So I engage. Engage what? Engage, I be with them. I provide my compassion, listening. I learn with them. I learn who they are as a human being, as a person first. I learn what their hope, what's the source of the hope, and how do they identify death and dying, and what's a peace for them, and do they need forgiveness? Do they need to forgive themselves and forgive others, and what's the culture background they come from. Also, we have many the culture assist models. And one example you can find online, we call ABCD, spiritual culture assist model. I learn with the patient, learn who they are. And in order to make the new connections, let them connect with their own resources. That sources is their inner peace and strength. Everybody has their own inner wisdom. No matter you call this God, temple, you call Buddha, Allah, whatever name you call, everybody they have one. They don't need we give them. So reason why in the clinical services, I do not teach them. I do not fix them. I do not judge them. I do not share my own life experience. That time, I think in this situation, okay, I know previous one patient, they use this coping skill very well. Do you want to try? We don't do that. We learn with the patient. We just assist them find their own coping skill. They always have their own inner wisdoms. So it just presents, present at by side over my listening ears. I just respond the emotions and be there, let them know you are important. I am here with you. I'm listening. I'm make this inner connection heart to heart with you. You should be proud of who you are right now. That's what I'm doing, present at by side. Also, I make referrals. Chaplain is one of very significant team members in these interdisciplinary teams. We make refer each other. We communicate, and we have every day we have a huddle. We discuss our patient. We read each other's chart. We work with the patient total pain. The total pain includes patient physical pain, psychological pain, social pain, and spiritual pain. We deal with the patient total pain. That's what a chaplain do in these clinical services. So now I'm going to give a case study. Is very simple examples. I want to show case study, let you maybe have more understanding about what I really chaplain do here. So this case is I have encountered one of the 15 years old Asian ladies. She has advanced and care flare, and also she's not a transplant candidate. Patient was on ECMO, also was intubated. And her only family member is her very supportive boyfriend. They stayed together for 15 years. So both of them are non-English speakers. So what is challenging is because the patient is living in very poor quality of life and totally rely on this ECMO and machines. So every time in the family meetings, every time we mention about the medical team, doctor mention about the transition to comfort care, or mention about your loved one does not have any good quality of life. The husband, this time is only boyfriend, he only repeat one sentence. I need she come back home. When this ECMO does not work, please, I want to replace a new one. No matter how do you talk with the boyfriend, only mention about the one sentence. So even doctor asked, could you repeat back what I'm just saying? The boyfriend said the same thing. I need her come back home. So then at this moment, so we had team meetings. We discussed. Since the most of the time, doctor said, we over communicate with boyfriend. How about the patient? We provide patient-centered care. Even patient on ECMO, intubated, always sleepy, does this patient have capacity? We want to know. So we refer to psychiatry. Psychiatry come and evaluate. We found that yes, patient have capacity. So team send me go to talk with this patient by side. I use we call communication tool. I use communication tool because patient is unable to talk. I use communication tool and with the interpreter. I told the patient, tell me what matters most for you. And the patient clearly told me that I have strong faith in God. This is not what the life that I want to. I'm ready to go. So then I bring the message to medical team. Then I go back to boyfriend. I ask him the same question. Tell me what matter most for you right now. He said, I want to. She back home. I said, okay, tell me more. Yeah, as we done, tell me more. He said, we know each other for 15 years. Yeah, but we have never illegally married. I want to marry her. I said, okay. So I corporate medical team, social workers, whole team. We set up a beautiful wedding at the bedside. And when the moment this couple exchanged their wedding ring, they both in tears. Also, that's first time I saw the smiling on the patient's face. It's also on her husband's face. So next day, we withdrew. And when the withdraw, the husband hold the patient's hand and tell her, yeah, I love you. You are ready to go. I allowed you to go. Yeah, I know God is going to taking care of you. So this is one of my case I had encountered in my clinical services. So as I mentioned, chaplain play a very significant role. And please make refer to a chaplain. When you make refer to chaplain, do not just ask, would you like to see a chaplain? Usually the answer from patient or family usually be, no, I'm doing okay. And I'm not dying. Also, that who is chaplain? What is chaplain? We don't know what the chaplain do. The better question is tell the patient family, the chaplain help you find the sources of strength to cope with your challenging illness or hospitalization. Would you like to see a chaplain? Or you can ask, chaplain help you find the strength and talk through the hard things. Would you like to see a chaplain? So you can use this way to make referrals. If you are clinicians, please make referrals because no matter patients and family members, sometimes they really need chaplain support. And if you are patient or family members, please request chaplain service because you matters. Thank you.
Master Longan, thank you so much for clarifying the role of a chaplain in the medical team.
Thank you.
It's kind of interesting, because I realized that in that last slide that I asked, would you like to see a chaplain? But it's usually in the context of someone who's very anxious. They have no one to talk to in the hospital and they want to talk to somebody. They really enjoy talking to the medical team. And you know what? A chaplain could be really helpful to, talk with you and support you. But yes, I will keep in mind that I should focus more on the role of the chaplain and not just ask if they want to see a chaplain. Okay. All right. So now we're moving on to our panel discussion and our Q&A. So if we can have all the panelists back on screen. So Jeannie has a question for all the speakers, or Jeanne has a question for all the speakers, which is, what is your number one challenge when working personally or professionally with Chinese or Chinese American patients and family members, and how did you address it or overcome it? Okay, so who would like to go first?
I can go first.
Okay.
Thank you. It's a very good, wonderful question. For me, as a Buddhist nun, as a chaplain, my big challenge is the service of I can say Asian Christian patients. Usually when they my dresses, I can tell majority of them say, oh, no, I have my face, I'm okay. Even sometimes I just go to discuss about one directive with them. When knocking the door, when they see my uniform, they say, No, I'm okay. I thought I come to discuss advance direct with you. They said, no. So okay, if you do not feel comfortable, I will ask my colleague to come. Is that okay for you? They said yes. So that is one of the major challenges for me as a chaplain. Thank you.
Yeah. Thank you for sharing that. I had never considered it. One of my questions was going to be for patients who actually don't specify a particular religious preference, how is a chaplain assigned? But I guess in your team, are you the designated chaplain for the palliative care team?
I'm a service, oncology, ICU, and so also palliative care.
I see.
But by the way, after I introduce my role, I'm an interface chaplain, I'm a unit chaplain. Yeah, after them, majority of them accept my services. I have to explain to them after that.
Yeah, this is Esther Lowe. So I'll comment. What a great question, Jeannie, and it's making me think. And I think for me, both professionally and personally, the challenge is not to make assumptions. I think as a Chinese person, sometimes I go in with, gosh, this is how my Chinese family brought up has been, and then kind of that can leak through in how I think about it for other Chinese families. And I think I oftentimes have to pause, right? Because realizing it's really not about me or my Chinese culture, but really what does this particular patient and family come with, and staying open-minded and curious and asking lots of questions. I love it that the panelist here says, tell me more. It's so important. So for me, I think it's trying hard not to make assumptions, even though it's my own culture.
That's right. I think that's a really important point to stress to healthcare professionals during trainings, is that we're sharing potential range of shared beliefs or customs or that kind of thing in the Chinese culture, but it doesn't apply to everybody homogeneously or across the board, because everybody has, just like brothers and sisters, you grew up in the same household, you may not see things the same way. So that's really important to emphasize. And I think Mindy had mentioned before that, she was relying on her own beliefs about dying at home, but certainly some patients have taboos against dying at home. And even though we tend to stress in our medical system that that's the preferred way to pass away is home hospice, but for some patients that may not be their preferred choice.
Can I also
Go ahead.
Barcelonian, I appreciate what you're sharing, and I will be one of those Asian Christian will say no to you. And this is an open discussion, but had I had a chance to listen to you, and I think it will help me and enjoy it. So do you ever consider not to wear a uniform? Because I guess the reason I used to go to Catholic school in Taiwan, and then although I'm a Protestant, but then I know the nun, they start not wearing the what do you call it? Their gown, and they seems to be when they go into serve in a school or different place, unless they mention it, people don't know their religious. But I just thought that I don't want to say it out of respect, but I just thought this is an interesting question, because I think we are trying to cater what the patient needs. And anyway, that might be a missed opportunity. That's what I want to say.
That's a wonderful questions. So yeah, many people ask this question, but my answer maybe really surprise you. Just because I wear these dresses, I got more referrals. Every time I pass the unit, we have glass store window. They saw my dresses. They said, "Oh, I need the chaplain. I need that monk." I asked the reason why. I had a reason when they see my dresses, they think of compassion. That's a reasons because I wear this dresses. I receive more referrals. I already have full of referrals, and I can tell my patient at Stanford more than 50 of them. 50% of them discuss meditation, Buddhist meditation, compassion with me. More than 50 of them. Maybe most of them, they are not identified Buddhists, but they practice meditation. They study Buddhist philosophy. That's really, yeah, maybe this answer surprised so many people. Opposite, really opposite. I think that this universe will benefit me.
Thank you.
Tenny, we had a question in the chat, which is kind of related, but they were asking what the Chinese Learning Circle is, and then also kind of tying back to the original question, is there any like #1 challenge facing with Chinese patients and family members at end of life, like that whole
So it's
topic?
interesting. This will be a good example to answer both your question. We want to do a support group, Chinese speaking support group, but we are afraid that Chinese, they don't usually open up to be vulnerable to share their heart. They just very guarded. They want to learn things. So we decided to call it Chinese Learning Circle, but Chinese like to learn. They, if you provide information, they'll come. So we thought we'd do that, and then we start getting, so we inviting speaker for different subject, and then we start, then the second part of the time, ask them if they have any question with their caregiving. So gradually the percentage of the speaker will be every, I don't know, every quarter or every couple months, and then more and more people start realize the benefit, and they are more comfortable about sharing their difficulties with others, the people who they don't know. And so that's kind of because we had to work around it in order for people to make that support group effective. And so we call it learning circle. So that's what it's for. Every second Thursday night from 5 to 6:30 is a Zoom. And we have people coming from all over the place because using the Zoom since COVID. We have people, family member already passed away, but they feel so connected, and they're not ready to let it go yet. So let people know if they need it. It's for the it is focused on dementia, Alzheimer's. Yeah.
Is the learning circle conducted in English or
No,
Chinese?
Chinese. There's a Mandarin speaking, and the other one's Cantonese speaking.
Okay. Mindy, do you have any experiences or challenges?
Sure, I have mostly challenges. I can't agree more with everything everybody was talking about. Like, sometimes the bias is from us and the judgment, because we also have some lived experience, and that's not going to be helpful for us to make connections. And I think the #1 lesson that I learned is to overcome that, or to challenge myself to learn more, is to really sit down and get their story. I first a social worker, and then now a palliative care person. I love stories. Like, I ask them like how they immigrated here, what they do. Those really give me like meat to talk about. Okay, wow, this is your past life, and then this is your recent, like this is your recent life, and things like that, just all sorts of material. And then what is really important is really getting back to the really basic and making human connections, and whether that's the patient making connections with themselves, and we can help them reframe and find meaning for their life, and then also help them let their family member know. So that is a really, really privileged journey that we're able to involve. And then I learn every day, and I learn to challenge my bias, and then learn every day from everyone. Very grateful.
Yeah. Thank you so much for sharing. And Dr. Luo, I think someone asked, like, how do you make a palliative care referral? So if you don't mind summarizing your answer.
Yeah, fairly easy, actually. Any patient, and also with even family members, of course, with the permission of the patient, can request a palliative care consultation from their medical team. And I would say outside of that, the medical team themselves oftentimes have ways, whether it's in the hospital or in the clinic, be able to refer directly to palliative care as well.
And I want to emphasize that, or reinforce what you were talking about is really essential to see palliative care not as an ally at the end of life, but during the entire illness, serious illness journey. So, so like what I think, I can't remember who was mentioning it, maybe that dementia or cognitive impairment is often a common sequelae after stroke, and sometimes that could be hard for people to accept or understand, and certainly if they haven't already talked about some of these topics beforehand, it could be a little more challenging to discuss it afterwards. Um, so, so again, just like the role of palliative care across the patient journey is really essential, and that it's not just end of life or cancer, that there's many other conditions that benefit from the care provided by
Yeah.
specialists like yourself.
Yeah, and I really liked how Master Yin introduced how to introduce Chaplain, and I think we can apply that to how to introduce palliative care. Because typically, what I see is the medical team may say, "Gosh, we tried everything we can, and there's nothing else we can do. We're going to refer you to the palliative care team." Okay. And so that versus if we said, "Gosh, there's so much going on." And let's have a group that can come and just support not just you, the patient, but the family to see how we can make things go a little bit more smoothly. Um, let's have you see the palliative care team, right? It feels very different. And so I think that's something I've learned today from Master Yin. What a great way of saying what palliative care is, right? And then introduce it. And I would say for those who are using interpreters, I think there might have been a question, I can't remember, that came up. I would always advocate for using an interpreter, even if the patient or even if the family member speaks good English, I would still offer that, especially if the patient themselves may not. They can decline, right? But we should always remember to ask for interpretation. And then as we use the interpreter in explaining what palliative care is, rather than say, oh, interpreter, we're the palliative care team and stop there. I would say we're the palliative care team and this is what we do. We're an extra layer of support. And then that way the interpreter can then just interpret what exactly the services that's being offered.
Yeah, because a lot can get lost in translation depending on what words they decide to use.
Absolutely.
Yeah.
Can I
Okay. And then,
chime in? Oh, sorry.
yes.
I have so much to say about interpreter service, and I love what you said, Esther, about not just palliative care, but add on more. And as you Google it, I get so frustrated. Like palliative care and hospice is the same words, and it said do nothing treatment, and I hated it. And when I sit there and listening to the only language I can hear is Chinese, and when the interpreter said that, and I can sense the silence across the board. And I said, please use this phrase later on in your career. So I'm very passionate about that. And if you were the one that using the interpreter service, and make sure that if you like in person, that you can sense the room. If you feel like you said something and the room temperature just dropped to 0, and that's probably not you and not what you said. And either you rephrase it or you said, well, thank you. If you do like like iPad interpreter and say, thank you, maybe we'll end right here, and you can always call up another one.
Yes. Yeah. That's one thing that I have found working at the county is that the in-person interpreters, the ones who are there day in, day out, the same ones that you see, they tend to interpret things more accurately, or it's easier to, have faith in their interpretation, because the ones on virtual, like either telephonic or on video yeah, sometimes it's a little hit or miss. Yeah. So thank you all. I just wanted to mention that in the theme of talking about AI, Dr. Jonathan Chen, he mentioned that, there are some ways that AI can emulate empathy and compassion, but it's not actually empathetic or compassionate, just knows how to say certain words that it thinks you want to hear. But like Master Longyan said, is that what you can offer, what all of us can offer for sure that AI definitely won't be able to, is our presence. So we are with, like, I really loved how you said, I'm here with you. And we're here, connected heart to heart. So just that compassionate, alert accompaniment and listening, I love that. So I'd like to invite Sandy Chen Stokes, founder of CACCC, to come say a few words, just her thoughts and any takeaways that she has as we wrap up.
Okay, I'm going to talk fast. Truly appreciate everybody to coming here. People at the audience, you might not know how hard for us to get such excellent panel groups together. It's definitely not easy. Everybody is so busy. So we are very fortunate to have all of you in the same room. This is the first time we've been doing annually the health professional forum, always in person. It's the first time is online. We turn out very, very good. So that's wonderful. I just want to say one thing because everyone, when you say it, I say, oh, if I can have time to talk, I want to say something. But now I just want to say one thing about the caregiver. What Tenny have just shared with us. I'm so happy I didn't gave up because she has such tight schedule. I chasing her until she has a cruise supposed to, but she decided to come here because I know Tenny for more than 20 years now. From the first time I met her, I look at her, she's pushing. I think she's just like an angel because at that time, dementia or Alzheimer is not well known and have a lot of stigma there. And she just fearlessly promote and educate people about dementia and the caregiver. And now, 20 plus years later, she's still doing that. I have to say right now we have about 63 million caregiver, paid and unpaid. And then a lot of non-unpaid caregiver like Tenny. She is a truly professional caregiver. She is not just care for all her family throughout her lifetime. And also she teach us. She's really fearless. I really truly appreciate what you just shared today because you show our human vulnerability. When we have caregiving fatigue, you say that out loud, let people know it's okay. Even Tenny go through that. When we're physically, emotionally, a list of manpower, we do have that emotional exhaustion. So that's the reason this year's our celebration, we want to honor all the caregiver globally. And so many things we can do. And Tenny mentioned about the, I think you say learning circle for our support group. CACCC, we have called support circle, which is come from the another Zen caregiving module. Caregiving support group is so important. We hope because of this event, we'll be able to find a way to work together. Doesn't matter it's from CACCC or from the hospital or others, to have that for Chinese support group because we all need it every day, all the time. Doesn't matter how much experience you have. I just want to say thank you and to everybody, Dr. Esther Lau, of course, she and Mindy. Mindy is going to be in China. We say CACC is like a bridge. We bridge every Chinese American or Chinese be able to exchange what we know and learn what we need to know. And then Esther has been in China, Wuhan and Beijing last year and the year before. and Mindy is going to be this year. I think that's what we are doing. We want to learn together to make this better world, serving the end-of-life patient and their family member, caregiver. So I thank you, everybody, to give us the opportunity to work together. Hopefully you will join us and contribute your knowledge and be one of our speakers. So thank you. And thank you, Emily and Jeanne.
Say thank you again, Esther and Mindy and Tenny and Master Long Yen. This has been an awesome forum, and I'm honored and privileged that you shared your heart and your professional work to the community. Now for the door prizes. Thank you for the audience that stayed.
Can I say something quickly
Sure.
before we go off? I just want to tell Sandy the whole thing is a full circle. My daughter, when she got a nurse degree, she decided to go palliative care, and she followed Sandy to Taiwan for 2 weeks. And I want to say that when I was taking care of my grandmother, every weekend, Friday through Sunday night, I brought 2 kids, at that time was 5 years old and 2 years old, and to take care of my grandmother. My grandmother for 3 years could not speak a word toward the end, but every 2 hours we had to turn her, and my kids fighting to feed her, to massage her, to caress her. I think it's 爱的传承, you know, the caregiver is powerful. And I think we were all put in on that position by design. And we should not let that kind of power go. It's a love, continue to go from generation to generation. And you guys are doing a great job. I really appreciate it.
Well,
Love
Tenny,
you, Tenny. We all
Yes.
love you for everything you did for the Chinese community for the past 3-4
Everybody
decades.
everybody's doing their part. And I think
Yes.
and we gotta continue to encourage other people, especially caregiver. Nobody wants to be, but if you have to kind of look at it from different angle, then it's much easier.
Yes, and thank you again, Tenny, for sharing your heart and your truth.
Thank you.
And it's very meaningful, so thank you. I don't know how I follow up with that with door prizes now. But we have door prizes, again, donated by ARP and ARP California and Dr. Pan. There's 2 books that Richard Louis, Enough About Me, is being donated by ARP and ARP California. And Dr. Pan is donating her book, Exit Strategies. Both books, Richard's and Cynthia's, are autographed. So the qualifier here for the people who have stayed in to listen to what the door prize is, and these are all awesome, excellent books, is that if you complete and submit the program evaluation that will be emailed to you this afternoon by 5 o'clock, 3 names will be drawn on August 29th, and you'll be notified by email that you are winning one of the 3 books. Next. Here's the book that Richard Louis wrote, Enough About Me, and it was about exploring the unexpected power of selflessness and the importance of sharing. And his father had Alzheimer's. Tenny, you probably knew that. And then Dr. Pan's book, Exit Strategies. It's about her sharing a heartwarming perspective of dying well and living better, tackling difficult conversations with humor. Once again, we want to thank all our sponsors and grantors making this program and all our other educational programs possible. Without their support, we would not be able to deliver these types of quality programs. Once again, final reminders. Program evaluation will be emailed by 5 p.m. today. Complete and submit the program evaluation by Friday, August 29th to qualify for the drawing. Allow 30 days for certificate of attendance processing and the door prizes. 3 names will be drawn on the 29th, and you'll be notified by email. Take a picture of this, My email is here. If you have any questions, please reach out, and we hope to see you at a future Chinese American Coalition for Compassionate Care event. Thank you.